Okay, now we should be talking about colorectal cancer, but before we go to colorectal cancer, we should have what are some other things that can present like cancer. They could be cancer, non-cancer. So what I'm talking about is polyps. You heard of polyps? What is polyps? It's mucosal growth. Mucosal growth that actually protrudes from the mucosa. Okay, polyps. So when you talk about polyps, we have non-neoplastic polyps and we have neoplastic polyps, right? So non-neoplastic polyps and neoplastic polyps. Simply neoplastic means, again, you can call it cancerous and non-cancerous, same thing, right? You can say cancerous or non-cancerous. At the end of the day, it's the same thing. Okay. Now, non-neoplastic cancer, so one category is known as hyperplastic. Hyperplastic. Okay, inflammatory. Inflammatory. And then hamartomas. Although there's many types, but I'm not going to talk about all of them. Hamartomas. Okay, you can have juvenile. Oh, there's one more that's important. I hope I can spell it. Peutz-Jeghers polyps or syndrome. Okay, and then neoplastic. Oh my God, I'll leave that for now. So at the end of the day, we have neoplastic polyps and non-neoplastic polyps. Neoplastic polyps are cancerous, non-neoplastic are non-cancerous. Good? Now, in this case, hyperplastic are just polyps growth because of diet and stuff like that. Inflammatory is strongly related to chronic inflammatory bowel disease, maybe ulcerative colitis especially. You can have in those cases. Hamartomas are benign growths. It's just a growth, extra growth, means nothing else. Peutz-Jeghers, it's hamartomas or non-neoplastic growth with skin lesions, with rash. Dark pigmentation, that's all. Dark pigmentation, like melanin pigmentation. So these are nothing to worry about. These are non-neoplastic, they're not cancerous, but nonetheless you can see growth. See, intestine is very sensitive. You know, if you irritate it, it can actually respond to that irritation by repair, and repair can lead to growth. Right? So it's possible, so that's very common in these areas. So growths are common, but not every single growth is cancerous. Non-neoplastic growths are non-cancerous growth. So one category is known as hyperplastic. Just the tissue has more tendency to grow faster. Hyperplastic. Hyperplasia means what? Increased growth. Inflammatory. These growths occurs because of inflammatory responses, inflammation, especially Crohn's and ulcerative colitis. Ulcerative colitis by far more. Okay. Hamartomas are just growths, benign growths, no pain, nothing, just growths. And you might find them on colonoscopy and stuff, no big deal, leave them alone. Peutz-Jeghers syndrome, it is intestinal growths in association with dark skin pigmentation. Done. So again, this is what it is. I'm going to forget this. So just as long as you know their names, so you're not surprised. Now let's talk about neoplastic polyps. Neoplastic polyps. See, polyps means growth of epithelium, epithelial growth, which protrudes out of the epithelium. Okay. Now, neoplastic growths are known as adenomas. They're known as adenomas. Adenomas. Okay, adenomas. So neoplastic polyps are known as adenomas or adenomatous polyps. Adenomatous polyps. If you want to call it polyps, you can call it adenomatous polyps. It's not just normal growths, it is actually glandular in nature. Adenomatous polyps. Okay, so let's say adenomatous. Adenomatous. You put T and O-U-S. Polyps. Polyps. Adenomatous polyps. These are cancerous. They have the potential to become what? Malignant. Cancerous. Non-neoplastic are usually non-cancerous. Usually. Okay? In majority of the cases. So, based on histology, let's discuss this based on histology first. Based on histology, these adenomas, these polyps can be made of tubular glands. That means these glands look what shaped? Like tubes. Tubulars. Okay. They can be villous. What is villi? What does villi look like?
Hair.
Hair-like. Okay, now if you magnify it, they will look like what? Fingers. Okay. Here, because when you look under the microscope, but you use a larger microscope like electron, you magnify it, you will see they're like finger-like projections. So villous means finger-like growth. Okay, finger-like growth. So it's not tubular; they are branched, let's say, or villous. Okay. Now, you can have the combination between the two. What would that be? Tubulovillous. Tubulovillous. Okay. Now, in terms of this, which one is more cancerous? Villous. Tubular less, then villous is the most, and tubular villous in between. They're more likely to become malignant. They're aggressive. They're no good. Villous. Villous is villain, like villain. Yeah, it's like, you're right, like finger, or like an octopus, or like a. What the term cancer comes from? What, guys? What does cancer mean? Not medically. The term cancer in Latin.
Crab.
Crab, because it has these claws that spreads out of its body. That's what cancer will grab onto you, hold on to you, and it will mesmerize you, and then it will spread. Okay, so when you think of villous, you can think of a crab. It means cancer. You know, there's a line called cancer, right? Around the earth. The equator, and then there's a cancer line too. I don't know if it's the equator line or whatever. Just something. Okay, so that's in terms of histology. You can only see this under microscope. But now let's talk about the types of adenomas. Okay, so look under microscope, you can see villous, tubular, or tubulovillous. Okay, so now one of them is known as familial adenomatous polyposis. Familial, meaning it runs in families. Familial. Adenomatous, it's made of adenoid gland type of tissue. Polyposis, a lot of polyps. A lot of polyps. Familial adenomatous polyposis, that means at least you must have 100 polyps to call it familial adenomatous polyposis. At least 100. You must have at least 100, otherwise it's not FAP. It's not familial adenomatous polyposis. Otherwise it's not.
They count it?
Huh?
They count it?
Yeah, of course. Of course, yeah. Don't be surprised. Now, what you can do is, see, now he's surprised. He's like, oh my God, I'm going to actually sit there as a GI specialist and I'm going to count them. What a boring job. When you do colonoscopy, you can see an area. Let's say this area is 1 inch area, you visualize. And that 1 inch area you count, there are 20 polyps. Let's just say for the sake of argument. But then you visualize along, without counting, that there is 6 regions of the same size involved. That's already more than 100. So there's an easy way, simple way if you can do things.
They are organized.
Yeah.
How do they agree with each other?
They're very tight, close, yeah?
They're not scattered like.
No. Usually you find a huge patch of it. Yeah. Okay, I see what you're saying now. Yeah, good. Okay, so familial adenomatous polyposis, there must be what? Minimum of 100 polyps. And this is autosomal dominant. Autosomal dominant inherited. That's why it's familial, so it's genetic. And the gene responsible for this is what? Adenomatous polyposis coli gene, APC gene. I'll put a gene next to it. At the end of the day, all you see is what? Polyps, polyps, and polyps. Guess what? If there's 100, the minimum requirement is 100 polyps. If you do find 100 polyps or familial adenomatous polyposis, this is 100% to become what?
Cancer.
Colorectal cancer, yeah. 100%. So it's no joke. So in young people, when you see polyps, You have to be careful now. You have to monitor them regularly. Maybe earlier you can do something about it before the cancer becomes large and puts this claws in your your intestinal wall and so forth, becomes true cancerous. Maybe you can just remove that little polyp and be okay. Okay, so early discovery helps. Okay, so second thing is you can have familial adenomatous polyposis plus osteomas, lipoma, fibroma. At the end, these are known as soft tissue tumors, connective tissue tumors. So if somebody has familial adenomatous polyposis plus they have connective tissue tumors, then it's known as what? Gardner syndrome. Gardner syndrome. Okay, then it's known as Gardner syndrome. Yeah, Gardner syndrome. Gardner syndrome.
Fat plus inhibition.
Yeah, FAP must be there. It's a form of FAP. In addition to what? It also has osteomas. Osteoma is the most common type. Elbow tumors. Think of gardeners. You know when you garden, what happens to your elbows and your knees? They get dirty. So most likely you'll have tumor in those areas. Okay, so maybe that will help you. Yeah.
What's the histology of the polyp?
Of polyps?
Yeah.
It depends. It could be tubular, it could be villous, it could be a mixed.
I mean the layers.
Same layers.
All the
Yeah.
layers of the intestine.
No, it's mucosal. These are only mucosal growth.
Only mucosal.
Only mucosal. It can extend. It can extend into submucosal and then muscularis, of course. But it's primarily mucosal growth. Okay, these are epithelial tumors. These are mucosal growth. If you have familial adenomatous polyposis plus, let's say in this case, meningioma, so let's say brain tumors. Brain tumors, brain masses. Meningiomas. Okay. Oligodendrioma, something like that. So brain tumors. Then you call it Turcot syndrome. Turcot syndrome. Turcot. Turcot syndrome. So adenomatous polyposis exists in three forms. Just familial adenomatous polyposis by itself, Gardner syndrome, and Turcot syndrome. Okay. All right. Yeah. Turcot. Okay, so at the end of the day, to resolve these, of course, the test of choice is colonoscopy. Colonoscopy. Once you do colonoscopy, if you see more than 100 polyps, it's almost always familial adenomatous polyposis, especially if the patient have what? Family history. If somebody comes to your clinic and then you do colonoscopy and you find out they have multiple colonic polyps, and you also ask them questions and they have family history, I mean, I wouldn't go further, at least for the purpose of exam. But just to confirm, because cancer is a bad news, right? It is always recommended, highly recommended, that you do biopsy. When you do biopsy, you'll find what? Malignant or neoplastic tissue. You'll find neoplastic signs like increase in mitosis, increase in spindle fiber formation, different stages of mitosis, neoplasia, anaplasia, dysplasia, all those you will see. And then that will tell you this is cancerous. Okay? So, now how you differentiate them? If it's bone tumors versus brain tumors, you will know it's Turcot or Gardner. Gardner's for bones, Turcot for brain. Okay. Some people say, like T Turcot for turban. So usually the tumors will be in that around the brain. So like turban, that's what you usually use that term. So far we talked about three things that can confuse you. Peutz-Jeghers syndrome. You have non-neoplastic growths or polyps, even though they can be many, but they're non-neoplastic, not cancerous, but skin rash or pigmentation. But then when you can have osteomas, they can present like nodules or something, right? With FAP, that's Gardner. If you have brain tumors in association with FAP, Turcotte, and we're done. Okay, that's polyps. Polyps are very common, so that's why you have to know all those types of polyps. Let's go now. Let's see this full-blown colon cancer, colorectal cancer. Colorectal cancer. There's also one more thing known as Lynch syndrome. Lynch syndrome. Lynch syndrome. L-Y-N-C-H. Lynch syndrome. Lynch syndrome is genetic colorectal cancer. Genetic. Those patients with Lynch syndrome, they will have colorectal cancer, gastric cancer, breast cancer, multiple cancer, usually more than 3 or 4 cancer at the same time. It's considered Lynch. It's autosomal dominant. Patient can have GI tumors, breast cancer, endocrine tumors, multiple tumors. It's not just purely colorectal cancer. It's colorectal cancer in combination with other familial cancer, like men 1 and men 2. Remember? Multiple endocrine neoplasia. So gastric, endocrine, and so forth. Think about this. But colorectal cancer, let's go. Now, colorectal cancer, of course, the underlying cause is APC gene mutation. What does APC stand for? Adenomatous polyposis colon. Okay, so APC always. Now, P53 gene mutation, which is tumor suppressor gene. Tumor suppressor gene. Can you have BRCA, breast cancer, gene 1? Yeah, again, it's tumor suppressor gene. So all tumor suppressor gene puts you at risk of cancers, colorectal cancer. This is unique for colorectal cancer. This is required usually. At least for step 1, you have to make sure that you know at least APC gene. APC and P53. Okay. Now, patient can have a mutation of APC gene, and they have P53 gene. It will take time. It will take time for the environment to contribute as well. Okay. Okay. Age is usually over the age of 65. Okay. What are other risk factors? You know. Diet. What kind of diet? Sedentary diet, low fiber diet, rich diet, not poor diet. Okay. Anything else? Constipation, yeah. So diet, constipation, let's just put this. Anything else? Huh? Family history, yeah. Family history. Anything else? Gender. Not, although it's in female you have it, yeah, but it's diet mostly. Ulcerative colitis. Ulcerative colitis. Okay. Let's go on to symptoms. At the end of the day, it's a mass in the intestine. That's all. Yeah. So in order to understand this mass, let's do something. Where exactly are the most common location of this mass? That's where the issue will come. So we have ascending colon, transverse colon, descending colon, sigmoid colon, rectum. What's the most common location of this mass? Sigmoid. So somebody's saying sigmoid. What's other location? Ascending colon. Okay. Now in sigmoid colon, the cancer is usually circumferential. Circumferential. The mucous membrane is involved in a circle formation. Circumferential. In sigmoid colon rectal area, it's most likely circumferential mass. Circumferential mass. And in ascending colon, it's usually a single mass. It's not circumferential. Okay. Which one will give you what kind of complication? So this will give you what kind of complication? Obstruction. So it will give you early obstruction. Although both of them can give you obstruction. This will give you early obstruction. And here you will get late obstruction. Ascending is late. Distal is early obstruction. Okay. Now ascending colon 1 usually will give you bleeding. Complication will be usually bleeding. Bleeding. That's the most important. Here it's obstruction. So obstruction leads to what? Constipation, right? Now the chief complaint of all colorectal cancer, we will start with what? Weight loss. One of the symptoms will be weight loss. Now if it's ascending, anemia. If it's ascending, anemia because bleeding, iron deficiency anemia. So the patient might complain of, oh, I have fatigue, laziness, pale skin, and blah blah blah, and dizziness. That'll be most likely ascending colon, because they're not obstructive in nature in the beginning. Later on, many years later, it'll become obstructive. Whereas sigmoid colon will complain of constipation first. Weight loss and constipation first. Okay? So weight loss, constipation, weight loss, or anemia. I mean, it can be a mixture of all three, but just to kind of give you some clues. At the end of the day, if there's constipation, wouldn't you expect distension as well? So you can have megacolon. Proximal to the mass, distal to the mass is no, but proximal to the mass or tumor, you will have megacolon. Yeah. Okay. So again, you can do barium, you will see a mass. Okay, you can do endoscopy, you will see a mass. They're all luminal masses, huh? X-ray you can do. X-ray might be, you can see megacolon mass, not so good. You might be able to. X-ray with barium, yes. When you combine the two, yes. Okay. Alright, so what's the big deal? Colorectal cancer is very common cancer. The big deal is it can metastasize. It can travel. It can travel. Metastasis will occur. Now, if it's in the rectal area and female, it's most likely to metastasize to what? Birth canal, ovaries, uterus, cervix. Okay? And men, bladder, urethra. The difference is you see between male and female, between urethra, bladder, and rectum. In female you have uterus, cervix, and birth canal. In men you don't. So in men, if it's forward extension, forward movement, then it's most likely going to cause urinary frequency or urinary problems. If it's rectal, not ascending colon. In female, it's most likely to cause what? Uterine problem, cervical problem, or birth canal problems. Okay? Good. So be aware of that. So maybe female will complain of bleeding after having intercourse. Men will complain of bleeding, after urination. Okay, so that's slightly different. The bladder and urethra in female is a little bit distal away. Between rectum and bladder and urethra in female is what? Uterus and cervix and birth canal. Yeah.
Could that be prostate cancer though?
Prostate cancer, same thing. Yeah. But we're not talking about prostate. So prostate can present similar in men. But remember, when you talk about female, they don't have prostate, right? Yeah. Okay. So at the end of the day, obstruction would be one problem. Complications are more important, so where would they travel? Number one is local extension, which talk about whatever is next to rectum. Behind rectum you have what? Not spinal cord. Yeah. So behind rectum you have sacral bones. So maybe if it goes upper, it will affect, it will cause cauda equina syndrome. So if you don't know what that is, let me write it down.
But isn't cauda equina a little too high?
Yeah, but it can travel there, yeah.
So it would cause like an osteoma?
Hmm?
Cause like an osteoma?
Well, not osteoma, it's metastatic, you don't call it osteoma. Osteoma will be primary tumor. Yeah. So this will be metastatic bone tumor. Okay? So it can metastasize there. It can metastasize to lumbar vertebrae, will cause lower back pain. It can metastasize to liver. It can metastasize to almost anywhere. Okay, so all the complications are depending on what? Metastasis and local extension. Locally, it will extend forward towards bladder, urethra, and things like that. Upward, it can go into, for example, jejunum and ileum as well. So complications are numerous because everything is tightly packed there, right? So it depends where the cancer moves and which direction does it go. Now, I give you homework in terms of what? Lymphatics. The primary spread of this cancer is lymphatic. Okay, lymphatic. Lymphatic spread is more common than blood. But of course, it can travel by blood too. If it travels by blood, most likely it will go to bones first, brain, bones, and liver, in those areas. If it goes to lymphatic, it will go to inguinal lymph nodes, okay, para-aortic or internal iliac lymph nodes, stomach, intestine, stuff like that. If it spreads within the abdomen, it's most likely by lymphatic spread. If it goes to the brain and bones and heart and lungs or liver, most likely it is by blood spread. Okay. At the end of the day, you can't do anything but remove it. Okay, remove it. So it's a big deal. Now the symptoms, always think of constipation or iron deficiency, anemia, and weight loss. Nothing more. Everything else is complication of this cancer, and that will depend on where is the location of this tumor. Where is the local invasion? Where is the distal metastasis? Okay, so symptoms will depend. You might have a patient not even complaining anything of GI problems. They'll complain of, not even that, they will complain of what? Respiratory problems, neurological problems. So it depends where it travels. Okay, so it depends where it travels. Okay, that's good. Any questions? No?